Thank you for the very warm welcome, and thank you so much, Sean, for taking the time to get to know me personally a little bit. I really appreciate it. So, ACA, HCA, who cares? Well, we all care, of course. Let's see. Is it on? How do I turn it on? We're having some technical issues here. Can you maybe just advance it? There we go. Perfect. Okay. Wonderful. Well, we all care, of course, because having a healthy economy means having a healthy population of folks in our community. And so, just to get the ACA, AHCA issue out of the way, because I will not give a political talk at all, but just to lay out what the Congressional Budget Office has said about this version of the ACA and the AHCA, is that the AHCA has no individual or employer mandate, as you're probably aware of. Pre-existing conditions are still covered under most circumstances. There is a penalty for discontinuous enrollment so that we incent people to have insurance since we do not have a mandate. And according to the CBO analysis, overall premiums will be lower. They'll favor younger, healthier individuals as opposed to aging individuals or those with pre-existing conditions. And you can see how it's going to impact the population. About 4% lower for about half the population in states that don't take advantage of the waivers that are currently built into the language of the law, and maybe 20% lower in states that take on some or apply for moderate waivers. That's about a third of the population. But bottom line is the affordability is going to impact the healthier population and the younger population more than the less healthy. Projections for the uninsured by 2026 under the ACA are projected to be 28 million, whereas under the AHCA, about 51 million. So I'm sure that everyone has their opinion about this law and how it's going to impact us all. Yeah, that'll be great. Thank you so much. But in reality, the individuals who get insurance through the individual exchange don't comprise the majority of the people who have health insurance. And what I did was this graph is a graph of the statistics from the state of Minnesota that show that employer-sponsored health insurance actually is, employers insure 56% of the individuals in the state of Minnesota. Only about 8% get their insurance through the individual exchanges. So as employers, let's just talk about insurance for employers. Certainly the ACA, HCA affects employer-sponsored insurance, but not as much as if you're buying insurance on your own. And this is data from the Midwest, not Minnesota specifically, but from the Midwest, for firms that are between 3 and 199 employees, and it comes from the Kaiser Family Foundation. So the 2016 annual premium is about $18,500 you're paying. Employers pay about 62% of that on average. Employees pay about 37%. The average deductible is close to, for a family, is close to about $5,000. That is not just for individuals who have a high deductible health plan. That is average across all employees who have employer-sponsored insurance. In addition to that, 27% of employers offer a high deductible health plan, and the average deductible in that subset of the population even higher. So let's just do a quick addition. An employee is paying about $7,000 a year for their family, but before their insurance even kicks in, they're going to pay about $5,000 in the deductible. $7,000 plus $5,000 is $12,000 out of pocket before your insurance kicks in for health insurance. That is an extraordinary amount of money, no matter what level of resources an individual has. So, we've transitioned into such a large contribution on the part of the employee for many reasons, cost-saving reasons. But one of the big reasons evolved out of Regina Hertzlinger's work at Harvard Business School, and she is really the mother and the grandmother of consumer-directed healthcare. And the philosophy behind what she has put in place and has evolved into these consumer-directed health plan designs is that consumers need to have skin in the game, whether it's for their dishwasher or whether it's for their health care. So if you get consumers skin in the game from an economic perspective, you give them choice and control, they are going to make the right decision. And so we've enabled that. There are, at last count, about 165,000 apps that help consumers be better healthcare consumers. And you can see what the growth of consumer-directed health plan, high-deductible health plans is. So we're at about 29% of the country has a high-deductible health plan. So the question is ultimately going to be, does it work? But where I wanted to start on this slide is that when we think about what an employer is designing for their employer-sponsored coverage, or what the government is designing, that's all health insurance or health insurance reform. So how does consumer-directed health plan design affect healthcare itself? And so I designed this slide to demonstrate that there's a healthcare continuum. How we finance it is what reform is all about. But there's a whole part of the continuum prior to that that happens between a doctor and a patient, or a consumer, a family, and it focuses around what medical services or healthcare services do you need, what options do you have, which of those services do you want, and then it becomes relevant as to what you can access and who will pay for it and what you will pay for it. So let's remember that when we talk about health and health reform, it's not just about who's going to pay and what they're going to pay. It starts with, what do you need, what are your options, and what do you want? But let me share some, and I'm going to share some facts with you. And in Regina Hertzlinger's approach, her theory is that if you give patients skin in the game, they will weigh into that whole beginning part of the continuum, and they will weigh into the decisions regarding what they need, what options they have, and what they want. But here are the hard statistics. Facts. 62% of patients want to participate in their healthcare decisions, but only 20% of patients actually raise the topic of treatment alternatives with their doctors. And specifically with cancer patients, where these issues have been looked at much more closely than even for other conditions, cancer patient decisions were concordant with clinicians only 38% of the time. So what does that mean? It means that if there were a series of options and the patient said to the doctor, well, what would you do? Or what would you do if this was you, or your mom, or your wife, or your husband? The choice that the doctor would select for themselves was only consistent with what the patient would actually choose for themselves 38% of the time, if the patient actually knew all of the pros and cons. So assuming that your doctor can make the right decision for you is sometimes valid, but most of the time not valid. So let's go back to Regina's theory that cost sharing and having skin in the game creates good consumers. So lots and lots of studies that have looked at whether or not consumer-directed health plan design saves money. And in fact, it does. If you impose an economic incentive for people to make choices, they'll make choices. And we know that healthcare coverage designs that are with a high deductible end up with a 12 to 14% decrease in the overall medical costs. And utilization of services decreases 18%. Sounds amazing. And for any of you that are employers in your room, or purchase benefits for your employer, or write the checks for those benefits, you have probably been approached by your broker or whoever advises you on how to buy insurance, that you could save money if you put a high deductible health plan in place. But let me show you one more thing. Just because medical costs decrease and utilization decreases when you give consumers skin in the game, it doesn't mean that they're going to be making good decisions. So that same study has shown that individuals that have a high deductible health plan do not use those apps that are made available to them. In fact, 15% of individuals only logged in one time to compare costs, to compare the quality of physicians, to really understand the pros and cons of the healthcare choices that they have. Preventive services actually were used 10% less. Well, that's not what we intended when we put high deductible health plan design in place. We wanted for people to stop misusing, abusing, overusing services that were unnecessary, and to appropriately use services, and preventive services is certainly one of them. But what we found is that cost sharing creates consumers. Yes, healthcare costs have come down, but not necessarily good consumers. So that is very important to keep in mind. So I'd like to share a story with you that's personal to me and to our family, and I was very close to it because it's about my sister-in-law, Carol. Carol is an educator. She is a feisty, 60-ish-year-old teacher. And about a year and a half ago, I got this email from her. My husband and I got the email from her. She said, "Hi guys, you probably guessed that something was up. Bottom line, I was just diagnosed with breast cancer. I have a lumpectomy scheduled next week. Then I'll get radiation. Do you think this is the right decision? I asked my doctor what she would do. She said I could get a mastectomy, but she didn't talk a lot about it. I just want someone to tell me what to do. I'm too emotional to talk, so just let me know what you think by email for now. Thanks, love you, Carol." I just want someone to tell me what to do for one of the most important decisions in her life. So let's talk about what decision making should look like. So often we think, oh my God, I have cancer and the doctor's going to save my life and they have to tell me what to do. But let's unpack that. Let's break that down a little bit. If we look at the decisions that the doctor needs to make, that Carol needed to make, and those that they needed to make together. So one, does she need breast cancer treatment? Yeah, that's a decision that a physician needs to tell you. So absolutely, the clinician is almost alone in the responsibility of telling you what you need. But lumpectomy and radiation versus mastectomy, absolutely equal outcomes. The responsibility of the physician is not to decide which one you have, but to tell you that you have both choices and to tell you what the pros and cons and the risks and benefits are of each one. The decision is Carol's. Reconstruction. The choice should be laid out. You can have reconstruction or not. It's simply cosmetic. The decision is Carol's. An oncologist, certainly she needs an oncologist. The fact that she needs an oncologist, the physician can tell her, but who she selects is Carol's decision. Same with the radiation therapist. BRCA testing to see whether or not she had the gene that would make breast cancer a hereditary risk factor, especially since Carol and my husband's family are Ashkenazic Jews. The availability of the test and the fact that it might be relevant given her demographic and her religious and cultural background should have been laid out to Carol. The decision whether or not to have it and the implication for her own daughters is Carol's decision. And then, if she was BRCA gene positive, should she have the contralateral breast preventively taken off or have surgery or have other procedures? My apologies for my backing to you. No. As you can see, it's not just tell me what to do. Carol has to weigh in, just like all of us do, to all of these very important decisions. And this is what we call in the industry shared decision making. And shared decision making has a very distinct definition and approaches. And a key tenet of shared decision-making is that only the patient, only the consumer is in the position to be able to evaluate the trade-offs that are present in any treatment decision, whether it's what blood pressure medication you take or what breast cancer treatment you have. In fact, there are many individuals who believe that it's a doctor's ethical responsibility to never tell you what they would do for themselves. Their responsibility, ethically, is to just lay out your options. So 93% of primary care physicians support this concept of shared decision-making. There are many, many studies to show that it leads to the best outcomes and results for patients, but only 10% do it. So having choices does not mean that people are even aware that they have choice. It doesn't mean that people feel empowered to make those choices. And it doesn't mean that people know how to make good choices either. And it is inevitable, so I'll beat you to the punch, that when I'm in a group like this, usually in the Q&A, someone will say, but the doctor doesn't listen, but it's intimidating, but they don't want you to come in with all of your questions. But there are a lot of buts about why consumers don't advocate for themselves. And actually, there are studies that that identify what some of the barriers are about how doctors get in the way of this important process of shared decision making. They don't have enough time. We all know that. They don't have the tools, the decision aids. They don't have the educational materials to be able to lay in front of you what the pros and cons and risk factors are. They don't understand this practice of shared decision making. Frankly, it's not something that you learn in medical school. It is not informed consent, by the way. Informed consent is not shared decision making. And it's also not when the doctor says to you, this is what I recommend, how does that sound? That's not shared decision making. And there's a whole insecure side to the physician community. Many believe, this is again a survey, this is not my opinion, is that patients aren't capable of understanding the evidence. And some are even nervous that laying out the options and not providing a recommendation may have patients feel like they don't have the right answer. So there's a lot of Superman ego mentality going on when you're in that doctor's office. But on the other hand, it's not just the doctor's fault. It's our responsibility. It's our fault. It's consumers' fault. And it's our responsibility as well. So other surveys look at what gets in the way of consumers taking charge of their healthcare decision making. Well, one of the things that comes out in my book and that I grounded myself in as I was writing it is that our core values as Americans is that we are really obedient. If you look at the World Value Survey, that looks at many different aspects of their behaviors of people around the world, we're one of the most traditional countries on the entire planet. We're religious, we follow instructions, we listen to our parents, our professors, our physicians, our just everything that starts with P. I lost all the rest of the words. So we are a culture from our founding fathers that ask for permission. And so we also have, we've imposed this whole language and hierarchical structure. Do you call your doctor doctor? Do they call you Mr. Deist? Do they call you Mr. Deisty? Probably not.
Probably.
They probably don't. So we create this language barrier and this hierarchy. They wear white coats, we wear blue gowns. So we've imposed that. And so patients say that there is a perceived power imbalance. And perceived is the right word, because I don't know whether it's real or perceived. And it's important to keep that in mind. I'm not sure that the doctor on the other side of the table actually believes that there's a power imbalance, but patients believe that there is one. There's, of course, the complexity of healthcare, and there's no question that it is complex, and as a result, people are not confident that they have the ability to weigh in to these very important decisions. We have a lot of jargon, and it's hard to sort through. And the regulatory definition of care does not lend itself to encouraging people to take care of themselves and to speak up. The only people that are licensed and paid for taking care of you are those that have a professional designation behind your name. But what about when you take care of yourself? What about when your family or community takes care of you? That's absolutely care. There's a huge ecosystem of care, but we don't pay for that. And so all of these dynamics have made it such that we say, what would you do? And look at the doctor just like that woman's looking at the professional in the picture. But it is absolutely critical that as consumers and that every person in this room overcome that barrier. It doesn't matter how hard it is. Everything's hard. But the benefits are the most important thing that you can do for yourself. And they're the most important gift you can give to yourself. Why? Because making informed choices increases your knowledge about what is wrong with you and why you're being treated. We'll talk more about that in a moment. You have a more accurate perception of your degree of risk, which is important. If you think that you're not at risk for lung cancer, you may not be incentivized to stop smoking, right? So having appropriate risk perception is important. Making informed choices means that your choices are aligned with your values. You have realistic expectations of the outcomes, but most importantly, making an informed choice, the formatting didn't work, making informed choices decreases the risk and dynamics of decisional conflict. So what is decisional conflict? Decisional conflict is when there's uncertainty about what action to take in any situation, and in this conversation about a healthcare decision. When you have decisional conflict, you are wavering between choices. You're concerned about bad results. You are changing your mind about what's right for you. You have distress and anxiety, and you're preoccupied with the decision. And if you don't resolve that conflict by getting educated and making an informed choice that you weigh into, you're going to have decisional regret. None of us deserve to have decisional regret. Just imagine how you would feel if you have a very serious illness and you have a less than ideal outcome, and you need to live with yourself and your family and those who love you and think, did I make the right decision? Did I know everything I could about this to weigh into the right decision? Because you only get a chance in those situations to make it one time. So if there's any reason to make informed choices, it's to avoid regret. So it's critically important that clinicians and patients recognize that they both have important roles to play in their healthcare. And sometimes we only think about the fact that it's the clinician that's the expert. They are, we are. We go to school for a long time. We know about medicine. We know about pathology. We know about diagnosis. We know about the right prescription strengths. But what we, the consumers, but what you are experts in is yourself. Your doctor does not know you. They don't know your values. They don't know your belief systems. They don't know the dynamics in your family. They don't know your financial situation, which is important. They don't know what your fears are. And so it's only if you combine the expertise of medicine with the expertise of you, which only you can bring to the table, that you come up with the best decision so that you can have the best outcome. Because if I didn't say it earlier, one thing to recognize is that there's, in medicine, very rarely, if ever, a single path to the treatment of any condition. There are very few conditions that only have a single treatment approach. You always have a choice. And even if it's the rare condition where there's one choice, you can always choose to do nothing as well. So you always have choice. And that's why I wrote this book. Carol's story is one of many stories. Obviously, you would think that anybody who has my email or cell phone number calls me all the time, and I'm happy to answer those calls. But in my role with KSTP, I also do Facebook chats with viewers, and so they can ask me questions, and I don't get as involved as I did with Carol. However, I do try to answer their questions, not treating them, but laying out options for people. And I've collected about 2,000 of them over the last 10 years. And the foundation of the book are the questions that I've received from Minneapolis, Wisconsin-based KSTP viewers. And so I got into my own head and I thought, how do I answer these questions? And there is a framework that I use in my head that I somehow constructed into this thing called like the CARES model. And the CARES model is a framework, a path, a guide, a map to helping people very logically move through the process of making an informed choice. So it starts with C, understand your condition, A, know your alternatives, R, respect your preferences, E, evaluate your options, and S, start taking action. Understand your condition. I know that's going to say, well, that sounds obvious, but let me tell you a fact. Only 50% of people know where the organs are in their body. Less than that know how their organs work in their body. And even for people who have a organ-specific disease like heart failure or pancreatitis or a problem with their spleen, those individuals don't know where that organ is either. So a starting point is knowing where the organs are in your body. I know that sounds really basic. But the point of the C is understand your condition by asking, so what? So if you are diagnosed with high blood pressure, well, so what? You're not treating a number. You're treating the risk of heart failure and an enlarged heart and a weakened heart in the future. That's a very simple example. So asking so what about your condition is critically important. Let me tell you how this played out in my own home when a friend came to visit me. So Deb is 56 years old. She came to my house one morning and she said, you know, would you look at my knee, Archelle? It's just been hurting. I think I had a bug bite. I looked at her knee and she had a 4-day history of a red hot swollen tender knee, and she told me she had a fever. And I looked at her and I said, oh my God, Deb, you may have a septic knee. You need to go to urgent care. And she looked at me like I was nuts. And she just wanted to sit and have coffee with me. I said, no, you need to go to urgent care. And I stopped myself dead in my tracks. And I realized I hadn't explained so what, and she hadn't asked me so what. And I translated it. And I said, Deb, the so what is you may have an infection in your knee that quickly destroys the cartilage that will give you a permanent arthritis. She said, see ya, I'm going to urgent care, right? I mean, how quickly it changes the so what. And how often do you hear you have X, Y, or Z, but you don't understand? So that's the first step. I'll go quickly through these, and if anyone wants my slides, because I will run through them, and I know that we're getting close on time, I'm happy to send them out. Use the internet, but avoid Dr. Google. Find a site that is evidence-based and credible. I use mayoclinic.org. I think it's structured so that any condition you look up, the information is always presented the same way, so you don't need to figure out how to navigate different websites every time. Step 2 is know your alternatives. Don't expect your doctor or your care provider to always lay out all of your options. If you're a hammer, everything looks like a nail. Trust me. An orthopedist that sees knee arthritis will always think about an injection or a knee replacement. There may be other options. So ask what else. I'll give the example of having sleep apnea. If you see a sleep specialist, they will most frequently start with a CPAP to help make sure that you get enough oxygen at night. You'll very rarely be told that there's a dental device if you have moderate sleep apnea that can push the jaw forward, that can treat moderate sleep apnea just as effectively as a CPAP mask. But it's done by dentists. So a dentist and an ENT doctor have different skill sets, and so one is not going to recommend the other. So ask what else and what are your alternatives. Warning signs, if you hear from a doctor, is, this is my recommendation. Okay, we'll ask, well, what are the other options? If this was my mom, listen for these code words because you want to know that you want to make sure that you're hearing all the options for you. Respect your preferences and ask what matters. You're asking yourself what matters. In this example, the story behind the example, goes back to a breast cancer example, which is that most breast cancer surgeons, just like Carol, believe that women want to preserve their sexuality by having a lumpectomy and radiation. And let's face it, most breast cancer surgeons are men. It's not exclusively men, actually this all breast cancer surgeons. So the male surgeons are assuming that women want to preserve their sexuality and therefore recommend that they have a lumpectomy and radiation. But if you survey women with stage 2B breast cancer, where this is an option, they just want to have their breast taken. They just want peace of mind. They want the physical absence of that tumor. They don't want to think about it having there. There's discordance between what your doctor thinks you want and what you want. So don't be a victim of that. Identify your own preferences and priorities. And those are different. Priorities are what's most important, and preferences are what's most desirable. And they fall into 3 categories: your medical outcome, your quality of life outcome, and your financial outcome. And in the book, you'll see how I lay out a process for actually working along a spectrum of putting everything on a scale of 1 to 10 so that you can figure out what's most important for you. Evaluate your options. Only you can do this. What gives you peace of mind? What's going to, when you look back in 5 years, what is going to make you think to yourself, I don't regret the decision? Even if it wasn't a good outcome, it was with the best information I had at the time. So deliberate and do it consciously. Brief story about my mom, 86 years old, 4 weeks ago was diagnosed with an anemia and a GI bleed. And she had my daughter's graduation at Columbia and my daughter's wedding here in Minneapolis just on Sunday to attend, and she needed to get better. Long story short is that her doctor recommended that she have a colonoscopy and an endoscopy. That was a risk for my mom at 86. We weren't sure that she would be able to survive that. And she read my book. She doesn't even speak English, easily. And she called her doctor for the first time in her life. She said, Dr. Mira, I'm going to postpone the colonoscopy. I really want to be at my daughter's graduation and my other granddaughter's wedding. And this is my choice. I'll have the colonoscopy in June. And I was really proud of her for that. So if we had time, I would show you my mom dancing at graduation. And then finally, start taking action and ask yourself what's next. You have a responsibility to follow through on your treatment plan. And so your role is to enable your own consumer empowerment. Your role is also to be a good patient, but you need to be actively involved. So be informed, be actively engaged, and ask smart questions by understanding your condition and being well educated. Feel empowered to make those choices. Separate out, distinguish between your doctor's professional expertise, that of course they have, and hopefully you've picked somebody credible, with their personal preference and bias. All of us have biases. And evaluate your own preferences and priorities, and then make good choices using evidence-based resources, and rely on a decision-making framework so that you can make sure you go through every step and so you logically go through to the end point that's right for you. So back to the CARES model, and happy to take any questions if we have 5 minutes.
Yeah, let's do it. We have time for a couple of questions, so let's 2 questions, please. Just go ahead and.
Hi, I actually just want to say thank you. My mother was diagnosed with cancer for the 7th time a couple of months ago. Brain tumor the size of a lemon. We didn't know what to do. And thankfully, she's received surgery. She has been recovering beautifully. I wish I would have had access to your book before that, because we didn't know where to go. So we actually contacted a lot of friends of ours within the family who are registered nurses, and that's where it was that we did the brunt of our research. So thank you for writing that book, because I really wish I would have had access to that a couple of months ago.
Well, hopefully your family won't face those sorts of medical challenges again, but you will face other healthcare decisions. And so you can use this framework not just for brain tumors or very serious illnesses. You can use this framework for whether or not you need to go to the emergency room to get stitches or whether you can use a Band-Aid, right? And so you can use this framework. For me, it's a go-to framework, and it's a reflex. You can learn to do that too.
Okay, one more question. Garfield has a question.
Are we getting value for all these dollars being expended, and if not, what's the solution?
Yeah. Very easy, quick answer.
I would say that I believe that the total healthcare bill that the country faces also includes overuse, misuse, and abuse. And so I believe that there's certainly a lot that we get value from, but there is a whole subset of services and treatments that aren't bringing us value. But we don't have the courage as a nation to create the systems to identify it and stop it, or to say, no, we're not going to pay for that anymore. So the short answer is no, but it's not so easy.
Very good. Well, thank you, Dr. Georgiou.